We're going to turn now to hear from Florida Blue. They're a leading innovator in building care models that are facilitating partnerships between patients and their doctors to foster better care coordination and cost-effective care. And joining us today to share their efforts is Dr. Eric Haas, the Senior Medical Director of Clinical Affairs for Florida Blue.
Good afternoon. I'm happy to be here and talk about some of our care programs with our physicians and what we're doing in terms of improving care. So I'm going to go to the first slide. So it's we'll be talking today about navigating oncology care, and we've got a approach here at Florida Blue that's dedicated to having a collaborative joint effect with our providers to manage in quality of care of our members. So ensuring also that the members get the right care at the right place, to get the most cost-effective outcomes. So with our partnership with oncology groups in Florida, we took a different approach at Florida Blue in partnering in a value-based type arrangement with 3 large tertiary cancer specialty groups in the state. Moffitt, these are employed oncologists in the Tampa Bay area. Baptist South, which is in the Miami area, again, another employed oncology group. And then an independent physician-owned group that's statewide called Florida Cancer Specialists. And the way that we set the ACO value-based relationships with the groups was to reward providers for beating cost target while meeting quality outcomes and standards. So the program has resulted in shared savings. We maintain our quality standards. We set targets for the different groups and then measure them and provide that feedback along the way, and made sure that we attributed patients in an attribution model to them. So in terms of some of the outcomes that we measure with the groups, certainly clinical outcomes around breast, colon, esophageal, pancreatic cancer. We make sure that we take patient satisfaction and patient safety into consideration. And then we look at adherence to treatment guidelines. Are the physicians following evidence standard guidelines that set out by the National Cancer Society, the FDA, or specialty society, depending on the cancer? The other approach what we take at Florida Blue is we've established a care team approach. So at Florida Blue, we've placed into motion an integrated multidisciplinary team approach of clinicians that have into 11 different zones in the state of Florida, where we have typical nurse role types, looking at patients coming into the hospital, helping patients get out of the hospital and transition. We have complex case managers that take care of oncologic patients. We've got community social workers that also assist our teams, in licensed care social workers to help with behavioral aspects, as well as clinical pharmacists for any issues as such. And how do we integrate this care? It's a hyperlocal approach, and we do it by a number of facets. So I'm going to just bullet down. So our complex case managers are triggered new diagnosed cases of patients who have cancer. They assist in a number of ways in coordinating a very complex, difficult disease for patients. They help out with coordinating to oncology visits, to follow up and making sure they're staying in touch with their PCP, their medical home, to assisting the patients in getting to the infusion sites. We have clinical pharmacists, which are just so important now with the cost of specialty drugs, and helping on complex drug regimens that are often fraught with not only severe side effects, but also the high cost at times hinders patients from really getting the care and ongoing they need. working with the oncologist to find other alternatives along care pathways for these particular patients. Community social workers have been instrumental really in helping in the social determinants of health, which no matter whether it be oncologic disease or other core chronic diseases can really impact the end stage of a patient's outcome. Marshaling community as well as faith-based support to help from anything from meals, transportation to housing, affordability, helping out in making sure that those basic needs are met, that's not an impact in terms of care that they need. Behavioral is something very significant as an underlying cause for not adherence to medications, to problems with adherence to physician visits, certainly with cancer diagnosis. Behavioral needs are great that we found for our patients. And with that, not only helping the patient, but more importantly, the caregivers and family. Our licensed care social workers have been very instrumental with the population that we serve who have cancer. Our teams are led by a nurse manager called a population care manager that reports up through our regional medical directors. Our regional medical directors have been instrumental in having peer-to-peer discussions with oncologists as well as primary care doctors on the difficult cases, helping patients in terms of where services can be rendered, such as some of the previous speakers talking about site of service of care. Certainly we encourage where possible to have infusions, for instance, done in the physician's office, outpatient, rather than subjecting patients to readmissions, cyclic into the hospital or into the outpatient hospital setting. Many patients have benefit designs within their plans that they will pay a significant higher amount out of pocket if they go into the hospital or if they use the outpatient hospital for ongoing oncologic needs versus having a physician being able to do it in their office. Likewise, the medical director may also have discussions on other care alternatives. Again, most patients have a different benefit design if they're going to be having repeat, let's say, CAT scans, PET scans, and staging of the cancer along the way, done in a freestanding physician-owned radiology facility versus a hospital-based facility. Likewise, not duplicating care. If a primary has done recent labs, making sure that it's not duplicated 1 week later by an oncologist, sharing of those resources, sharing of what has been done in terms of staging of cancer. Our medical directors have been very integral in this process of really closing the loop between the oncologist, the primary physician, who is our medical home model that we execute at Florida Blue, as well as then assisting the patient and their family with that approach. We also are focused with giving patients the ability, especially patients with metastatic cancer, not in active treatment anymore, to at least have some assistance with palliative care, making sure that their wishes are known, assisting their family in a difficult time, I think is another key component of our place of delivery model, and assisting on the palliative care side of care. A lot of times just focusing on the disease itself without really getting that holistic approach that I'm describing, from the social determinants to the behavioral to the palliative, will not have the best overall outcome for that particular patient. So today I've described what we try to do with physicians. We're very much into partnering, collaborating with physicians in terms of our ACO models that we are now employing statewide with these large cancer groups, oncology groups, as well as then how do we take care with our own internal multidisciplinary teams, a very difficult disease being cancer, and how our different role models within our PODS model execute on that. So I'll be also taking questions and answers towards the end when the others finish. So thank you very much.